Okay, so this group of lectures is going to examine some of the more commonly encountered drugs that we can use to treat epilepsy. Learning objectives. And so understand that epilepsy, of course, affects upwards of 2.5 million people here in the US, and within the world's population, 1% of the entire population is affected. I've always thought of seizures and epilepsy as arrhythmias of the mind. And there are 4 kinds. And of course, Dr. Hall and Dr. Hefner will spend a lot more time discussing the 4 different types. But essentially what I've done is I've looked at your STEP prep guides, and this is directly from the STEP prep guidebook from last year. And basically what they want you to know are what are the effective drugs for each of these seizure types. And of course, if you just glance at this, there is some overlap. And I think this is really kind of the crux of what you need to prepare for step 1, because obviously the treatment of epilepsy is really a kind of a subspecialty, and just 4 years of medical school is not really going to make you qualified to treat epilepsy. But we're going to look at 3 major mechanisms which are listed here, and these are basically the 3 main drug classes. And so there are certain conditions or drugs that can affect what's deemed the seizure threshold: heavy metals, mercury, lead, aluminum, certain infections, several illicit drugs, several prescription drugs. All of these can lower the seizure threshold and produce these conditions. Outside of the drugs that we're going to talk about, there are some non-drug treatments that have been suggested in the literature. I'm not going to spend any time on these because they're not drugs. So to me, they're not important, but they are important, of course, from the clinical management, and you can probably hear about at least some of these from the various disciplines. So the first group of drugs that we're going to look at are the sodium channels, and so the sodium channel blockers, rather. And so in terms of just kind of treatment strategies, the first thing we really want to do is suppress the seizure focus and then prevent the spread of the next focus. And so the main group of drugs are really the sodium channel blocking drugs, and several of these are listed right here. Understand, of course, that the sodium channel exists in 3 states: open and conducting, closed and not ready, and closed and ready. And a lot of the pharmacology textbooks pay special attention to which phase of the sodium channel these drugs inhibit. And I don't think it's clinically relevant. I think it's conceptually interesting. One could argue that the pH of the environment can affect the movement or the transitioning between these 3 different phases within the channel. But I don't think it's that clinically important. Here's the nice kind of a schematic representation of the sodium channel, and of course, we've got certain drugs binding to different components or different protein targets within the channel. And again, I think that's kind of beyond the scope of this course. If you're an epileptologist, of course, you can spend probably all day looking at this stuff. But I think for what we're trying to do here, this is a little bit more than what we need to know. What I do like about this diagram is that basically it shows the action potential spreading, and you can kind of follow it and see the importance of sodium through this propagation. And so the first drug we're going to talk about is phenytoin, and what it does is it's a sodium channel blocker, like many of the other drugs in this particular lecture, and it's going to slow the influx of sodium into the cell. And if you do that, you're going to very dramatically slow the action potential. And of course, if you slow the action potential, you're going to reduce the excitability of these neurons, and you're going to slow the neuronal transmission of this electronic message. And so the first drug we'll examine is phenytoin, and this is a sodium channel blocker, and it does have its effect at the sodium channel in its inactive state. and then it's going to prevent the seizure from propagating. Now, phenytoin is important historically for pharmacology because it's got some very unique attributes. From a pharmacokinetic and pharmacodynamic standpoint, it has variable absorption. And this is problematic when you compare phenytoin formulations across different drug manufacturers, and we'll spend some time about what the clinical relevance of this is in a few moments. Other things about phenytoin include the fact that it has zero-order kinetics, much like ethanol. And so from a pharmacokinetic standpoint and looking at calculations and dosing, this is problematic in terms of some of those formulas. It does have a tendency to induce CYP enzymes, and I'll show you what that looks like in a few minutes. And this drug also has a narrow therapeutic index, meaning there's a very fine line between treating at an appropriate dose and treating at a dose that produces toxicity. Okay. Let me move this out of the way over here. Clinical indications, of course, are different types of seizures, but this drug is highly teratogenic. In women who are given this drug or who take it accidentally, their babies often develop cleft lips and cleft palates. Phenytoin itself is responsible for numerous drug-drug interactions as a result of these induction pathways via the CYP enzyme system. Side effects are pretty dramatic. You can see everything from CNS depression, you can see hyperplasia of the gums, you can see excess hairiness, osteomalacia, and then blood disorders, including megaloblastic and aplastic anemia, as well as a rare but well-tested side effect called the Stevens-Johnson syndrome. And I'll show you what that looks like in a few minutes. So let's spend some time on elimination. Remember, this is going back to the LADME components of the pharmacology curriculum, where we're essentially looking at how drugs are eliminated through the system or excreted through the system. And the majority of the drugs out there basically utilize first-order elimination. And graphically, this is what this looks like. But phenytoin, as well as theophylline, which we talked about in the asthma lecture, and alcohol, which we've mentioned in different instances, has a zero-order elimination. Okay, and so this elimination rate is constant, and it's independent of the amount that's administered. So it's a fixed amount that gets reduced every incremental time component through this pathway. And so that makes dosing phenytoin somewhat problematic. Other things that kind of feed into zero-order reaction kinetics include a slow biotransformation rate. And so the body, for various reasons, cannot tolerate or accommodate high molecular burden of these compounds. Some of these drugs are low potency, and so they require high doses, and that increases the molecular burden. And then phenytoin specifically is associated with numerous CYP isoforms. There can be fast and slow metabolizers, like in the CYP2D6 story, but phenytoin itself offers dramatic alterations of the CYP enzyme pathway, which is shown here. And so these are all the different CYP enzymes that are responsible for the various metabolites of phenytoin. And so phenytoin itself is a strong inducer of these CYPs, a moderate inducer of these CYPs, and this is really the basis for many of the drug-drug interactions that exist out there. Now, to kind of overcome some of the problems with absorption, there are some different formulations of phenytoin. I'm only going to talk about one, phosphenotoin. It works identical to its parent compound, but from a pharmacokinetic or from a dosing perspective, this formulation of this drug offers a more controlled absorption. And so the things that are packaged in with the capsule, the fillers and the excipients and some of these other compounds, offer a more controlled and predictable absorption. And so that kind of feeds into the elimination pathway in terms of its zero-order kinetics, but also its ability to be highly bound to various proteins. And so there are other derivatives out there. We're not going to spend some time on those, but you do understand that these other derivatives are basically kind of getting at the same point, trying to offer more predictable and more streamlined absorption through the LADME system. And the reason we have to consider this is because excuse me. The reason we have to consider this is because in almost every drug that we've talked about so far, brand name drugs and generic name drugs are essentially the same. And that rule really doesn't apply in the case of phenytoin and Dilantin. So Dilantin is the brand name drug and phenytoin is the actual chemical. These drugs are not always biologically equivalent, meaning that, if you look at the area under the curve, this could be the area under the curve of Dilantin, this pink graph, and then the bluish-green graph could be the area under the curve for phenytoin. And so you can see that the minimum effective concentration is not actually reached for phenytoin. And so this is a great teaching point by example where you've got two drugs that are the same chemical entity, but because of the formulation and because of the fillers that are associated with this tablet, they don't offer the same absorption. So if these were virtually identical drugs, you'd see the same slope right here. They'd almost be basically the same graph, and they're not. And so this is problematic when patients, especially insurance companies, try to force patients to go from the brand name Dilantin to the generic form. You have to do plasma concentrations while you transition them over to the generic form. 10 milligrams does not equal 10 milligrams. It might be 10 to 8 or 10 to 12 or something like that. But this is a great kind of teaching point, and I think it's one that's important. And if you look through the case, this is really kind of the first time we've left a brand name drug in the patient's case, in the patient's medication history, and we didn't change it to the generic form. Okay, so there's a few drugs that are like that, and we'll review those at the appropriate time.